Hello, my name is Ruben Ocampo. I'm a person who 3 months ago was having difficulty breathing. The difficulty kept worsening, and it even got to the extent that I would have 10 to 15 crises a day. This was the main reason that I came to Blue Net Hospitals with Dr. Juan Jose Chavez. I thought some x-rays would suffice. He suggested a CT scan, and it turned out that I was not sick as I thought. I actually had a hole in the diaphragm. The hole was so big that it allowed the colon to climb into the chest. Which is obviously not a natural area. And this misplaced organ became a threat to my life.
Hello, my name is Dr. Juan Jose Chavez. We recently had the opportunity and the fortune to treat Mr. Ruben Ocampo. Mr. Ocampo presented with us after sustaining and having been diagnosed with a diaphragmatic hernia at another hospital. He came us initially requesting for a second opinion. During this second opinion, we were able to diagnose and detail exactly the size and width and difficulty of the repair of the hernia. This diaphragmatic hernia caused serious difficulty during breathing. The difficulty of breathing was caused because the colon collapsed the lung on the left side of his chest, and this restricted Mr. Ocampo's breathing. This was such a grave disease that he thought that this could have been a cancer-related disease or a pleural effusion or another lung disease. All of this was discarded with more efficient and effective studies.
A CT scan is a study where virtually you are sectioned as if you're watching the top of a sliced loaf of bread, taking the image of the bread. Imagine that in these cuts, you saw my colon at the space where you should have seen my lungs. In my particular case, the colon was pushing on my lung and was giving me a hard time breathing.
Once the diagnosis was detailed, we then took the determination to operate on Mr. Ocampo. The decision of the surgery was taken together with our affiliated hospitals. We work with a number of hospitals that are affiliated with us, like the UCSD and Stanford University. They assist us and advise us during complex procedures such as the surgery required by Mr. Ocampo. In this particular case, Dr. Anthony Pericone from the UCSD came here to assist us.
When the doctor decided to perform an operation, he talked to me about having a support team from one of the hospitals they are affiliated with in the United States. This boosted our confidence as we demonstrated that this is not a battle of egos. Here there are no rock stars. There is just one patient in need that is talking to you. We then were informed that a thoracic surgeon, Dr. Pericone, would be the one opening my chest. We got further reassurance from our referring doctor, which also enhanced the confidence. I received a call from Dr. Pericone's office, and after talking to him and hearing all that he specializes in at the UCSD, I knew that along with Dr. Chavez, I was deemed to succeed. By having all these previous arrangements and conversations, my wife and I were able to come into the hospital with complete trust. I arrived a day early to prepare, where I had a colon preparation, very carefully avoiding dehydration. This allowed me to go into the OR strong and aware. After that, some hours were gone.
During his visit, Dr. Pericone advised us to select the best surgical technique that could adapt and resolve Mr. Ocampo's problem. The form in which he decided to approach the patient and was what we eventually did in the surgery was by a thoracoscopic approach. This means introducing a TV camera or a scope in his chest. By doing so, we were able to distinguish all the structures that were found in his chest. We identified the lungs, the hernia sac, and the lung, as well as all the adhesions or scars that were formed between the bowel and the thoracic wall. By thoracoscopy, using the same TV camera, we were able to detach most of all the adhesions that were stuck to the chest wall. Those scars would have been very difficult to detach if we would have employed only a thoracotomy, making a big incision, which means that instead of using a camera, if we had made an incision, this would have become a much more difficult problem, a much more prolonged problem, and obviously a much longer recovery period of time for Mr. Ocampo. The use of thoracoscopy allowed us to also visualize the defect of the hernia. We were also able to select, by this way, a better placement of the incision, leading to a better recovery to Mr. Ocampo, by doing the incision a little bit lower. By doing after detaching all the incisions, we then decided to make an incision. We were able to open the thorax, and we were able to identify the whole elements of the hernia sac. The hernia sac was made of a large segment of a large bowel, and it was also made of a large part of omentum. We had the need to remove the larger omentum, and this weighed about 1.5 kilos. This allowed us to visualize completely the defect of the hernia, which was just at the center of the diaphragm, and allowed us to return the colon back to the abdominal space. This probably was related to Mr. Ocampo's original automobile accident. Once the colon was placed back in the abdomen, we were able to identify the edges and the borders of the diaphragm along with the defect of the hernia. The defect of the hernia was of approximately 10 centimeters. This required for us to place a special mesh to the diaphragm, which was able to complete the continuity of the diaphragm and isolate the spaces from the lung and the spaces from the abdomen. After the end of the placement of the mesh, we were able to identify that the lung expanded appropriately. Afterwards, we placed the chest tube, and the chest tube allowed for the lung to complete the expansion. After the surgery was concluded, the patient was successfully woken up. He did not require extubation and then went on to pass to the intensive care unit. At the intensive care unit, he was submitted to pulmonary physical therapy with a continuous monitoring of his hemoglobin. All of this is allowed and permitted because of the extensive equipment that Blue Net Hospital has at the intensive care unit at NWR. The successful and effective management of the intensive care unit allowed for Mr. Ocampo to leave the intensive care unit after only one night of staying at the intensive care unit. He was then moved to a regular room where he completed his 4-day recovery.
The surgery was finished. I did not know at what time I woke up. I was in pain initially, but it significantly decreased as time went by. I had a tube that was used to drain fluid collected around my lung and to expand it. It was removed today, and it became a wonderful day where I have no pain and feel happy, as it is a matter of time to be completely well.
Today, we had the fortune to send Mr. Ocampo home. His lung is completely expanded. He has no difficulty to breathe at all. He is not oxygen dependent, and his large bowel is completely within his abdominal cavity. He is now breathing by himself without any necessary or auxiliary support. This will allow him to have a normal life within a relatively short period of time. He will be completely functional after 4 weeks. It was a very complex procedure. We had the assistance and support of the hospitals we are affiliated with in the United States. Our personnel and our staff that we usually work with makes this possible, and now makes things possible that couldn't have been dreamt up before in Los Cabos. Nowadays, there is no need to travel to other cities to get more complete treatments. This is all due to the capacity of the professionals that work at the hospital, but also due to the technological advances and equipment that we have at BlueNet hospitals. The idea that these procedures cannot be longer done in Cabo is way past gone. In Los Cabos, we are able to resolve practically every medical situation, particularly in BlueNet hospitals. We have the best trained personnel, not only physicians, but also technicians, nurses, pre-medical doctors, and of equipment. We have the most advanced technologies in CTs, in imaging, in diagnostic studies, and EOR equipment. All of these resources are dedicated to care for our patients with quality, with warmth, and with the integrity that is our trademark in the care of all of our patients. We not only cared for his medical aspect, we also were very aware of his personal needs and his emotional needs, which were assisted at the time.
I do not want to ignore the institution because the hospital has been very helpful to me in the sense that they are completely equipped with the newest technologies. This conversation is 4 days after my surgery, which is nothing. At this point, I'm surprised to be talking. My voice is intact. I am not short of breath at all. This is because my lungs are intact. 4 days ago, I could not even tell you any of this today. I live gratefully since I couldn't be saying very different things. I am in love with God, and that love maintained me convinced that I remain protected through the doctor and this institution. Having said all this, I will let you know that I am a disabled person. I cannot move from the waist down. I lost that ability over 20 years ago, and knew this made the prognosis much more limited. 4 days later, I'm telling my story, and I'm telling you, nothing happened. I'm completely healthy, and what follows is to complete my physical therapy to honor the doctor's surgery.